Good evening, ladies and gentlemen. Thank you for joining us today in a new episode of Imdad's webinar series. Today's webinar will tackle the issue of vitiligo and psoriasis management, not just on the medical level, but also the social and psychological aspects of the two conditions. We will particularly focus on the utilization of now banned UVB as a prime solution that helps alleviating the ramifications of both conditions, as well as introducing home phototherapy as an accessible and cost-efficient remedy that suits many cases' needs. We are elated to be joined today by two of the most prominent and well-versed speakers in the field of psoriasis and vitiligo management. Our first guest tonight, who definitely needs no introduction, is Professor Abdulmajeed Alajlan. Professor Abdulmajeed is the head of the Saudi Psoriasis Group and the treasurer for the Saudi Society of Dermatology and Dermatologic Surgery. Professor Abdulmajeed is a consultant dermatologist in the Department of Dermatology, King Saud University. He is also the supervisor of the Phototherapy unit at the same university. Professor Abdulmajeed received fellowship in laser and phototherapy from the University of British Columbia in Canada. Dr. Abdulmajeed also published a plethora of papers and research in the fields of dermatosurgery and clinical dermatology. Joining him today, another illustrious fellow of the Laser and Phototherapy program from the University of British Columbia, Professor Illtefat Hamzavi. Professor Hamzavi has served as founding co-chair of the Global Vitiligo Foundation. He received his medical degree from the University of Michigan Medical School and currently teaches medical students at Wayne State University. He is a senior staff physician at Henry Ford Health System. Dr. Hamzavi has co-authored over 300 peer-reviewed papers, which have been cited over 6,000 times. During the session, you are welcome to direct any questions to our esteemed speakers using the Q&A tab at the bottom of the screen. These questions will be addressed by them after the end of the lecture and during the question and answers segment. Without any further delay, we will now dive into today's topic as Professor Abdulmajeed will start by examining the fundamentals of the two conditions on hand. Professor Abdulmajeed, the floor now is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Ahlan wa sahlan. Good evening, everyone, in this lecture and these scientific activities been sponsored by IMDAD, and we are really thankful for IMDAD to have us here with you to share with you some of the knowledge that we have to help our patients. Thank you very much again for you to attend this scientific meeting. Thank you for Professor Hamzavi also to share with us his experience in phototherapy. I'm going to start with you as an introduction for vitiligo and psoriasis, which is I think the two major diseases in Middle East being treated with phototherapy, and really our patients in great need of phototherapy for these two diseases. Let's start with the prevalence of the disease. As you can see in this slide, that in psoriasis there's a big range of incidence between population to population. As you can see here, globally, it's between 0.5% to almost 10% in certain population. So it's big differences according to the genetic makeup of each population. However, in our Middle East, it is mostly around 3 to 4% of the population may develop psoriasis in their lifetime. So it is significant that each 100 person in population, 3 of them might be affected with psoriasis. So it's it's really significant. If we come to vitiligo, the percentage is around 1%. Again, it's still significant. So if you want to know the size of the problem in our Middle East, it's almost like 400,000 patients really need treatment with either psoriasis or vitiligo, seeking medical advice in our clinic. So it is almost 500,000. So it is a really significant health issue. If we want to talk about the pathology of vitiligo, if we start with vitiligo, I think most of us, we know that melanocyte is the culprit for immune system to be attacked by our autoimmunity. So there will be an abnormal cellular stress response that happen in melanocyte. What that leads to autoimmune triggering of T cells that will start, as you can see here, to attack melanocytes. And it is very specific and very selective autoimmune attacking, in which if we took a biopsy, the inflammatory response is not so huge, but only towards the melanocytes. So it's very selective autoimmunity against melanocytes. So what will happen then after? The melanocyte will be destroyed, and as a result, the pigments will be lost, and the vitiligo will appear on a patient's skin. There's, of course, the genetic susceptibility of each patient, and there's an intrinsic function abnormalities that happens in the affected skin to make the patient develop the vitiligo, and it will be apparent in his skin. So not in each part of the skin this abnormality happens, which tells us there's a variability between a site and a site, a patient to patient. So it tells us that is not the mechanism of action is not really full understood. But in general, we know that melanocyte is the culprit or the target for autoimmunity. So what happens at the cellular level? We know that CD8 cells is the one will probably take the leads towards the melanocyte, in which through interferon gamma release, the melanocyte will be attacked through the CD8 activated cells. Inside the melanocyte, the JAK receptors will be activated, and the STAT also receptors in the nucleus also be activated. And interestingly, there will be like a circle of auto-activation, and that's what happens when patient develop vitiligo. That means there will be probably a more increase of new lesion will happens because of this auto reactivation through the CXCL cytokines, as we can see here. So this circle increase the appearance of vitiligo in those patients. So if we are able to suppress the CD8 cells, or to block the interferon gamma, or at least to block the STAT or JAK inhibitors, I think we'll be able to touch on the management of vitiligo. And this is what we have seen recently. Those patients who took JAK inhibitor for other diseases, his vitiligo might improve, and I have few patients like that. So if it comes to the morphology, the clinical features of vitiligo, it's very heterogeneous clinical features, from localized to generalized to segmental to acrofacial. And I think dermatologists in the Middle East necessarily has see many patients with vitiligo with different morphology. None of them actually has specific pathogenesis different from the others, except probably the segmental vitiligo, in which probably it's related to the genetic makeup, so it's be localized on one side of the body. Otherwise, the other part of the disease there's nothing has been pinpointed. The pathogenesis makes them more peculiar than the others. For example, for the management issue or for the diagnosis issue. So it is a heterogeneous clinical features. Patients with vitiligo came to our clinic. Let's go back to psoriasis to talk about the pathogenesis. In the pathogenesis of psoriasis is more obvious more than vitiligo, and the reason is that the researchers and the scientific chairs taking care of psoriasis is much more, and there's a lot of interest in psoriasis all over the world, and this is why probably the pathogenesis is more clear, where the innate immunity is start to be activated, and we know that the keratinocytes proliferation will be started once the trigger started through the tumor necrosis factor alpha and the interleukin 17 and interferon gamma. And we know that the inflammatory milieu started against keratinocytes in the epidermis. And what happens? The keratinocyte will be activated and start to proliferate and control in non-controlled way that results in a hyperplasia, and that hyperplasia manifested in patient with the scales, redness, and psoriatic plaques. So we know that keratinocyte is the cells affected, and the melanocyte, the treatment, the tumor necrosis factor alpha interferon 17 is the main signaling pathway in the pathogenesis of psoriasis. So our aim is to cut through this inflammatory milieu activation to help those patients. So again, for the type of the psoriasis, again, it is heterogeneous, and there's many types of psoriasis. These are just part of the example, like plaque psoriasis, pustular psoriasis, probably palmoplantar psoriasis, guttate psoriasis, and many others, epidermic, scalp psoriasis, nail psoriasis. Again, the differences in the pathogenesis on each side of them is not necessarily has been understood, except nowadays in the pustular psoriasis, in which the IL-20, IL-36, where it's been recognized to play a major role in the pustular psoriasis, and that understanding helps the researchers to find out the treatment option or the treatment culprit to block that cytokines. Again, this is just how we assess the psoriasis severity. Probably it's not this. We know PASI score. I'll not go through that because this is mainly when we are planning to do research or to shift the patient to more like systematic therapy to make sure that patient is really in need of that systemic therapy. But if we go more in the patient interest, which is the psychological and social implications, no doubt, vitiligo and psoriasis, one of the major, really major dermatologic disease affecting the psychology of the patients. Vitiligo, as you know, in your patients, probably many of them really frustrated from the vitiligo, being stigmatized, and in certain study, the marriage potential decreases by 50% or affected in 50% of the patients. And there's no doubt on that because of the culture of our community against vitiligo. And we know that vitiligo is a big challenge for the doctors and for the patients when patient comes to the doctor's office to help them. In Saudi Arabia, almost 1/3 of the population think that vitiligo is contagious, or let's say it can be easily transferred from a patient to other normal person, so they will be avoiding that person, and this is why it increased the burden and the challenge for the patients. It's no doubt that depression, and no surprise that depression found in 2/3 of the patients with vitiligo, and that has been documented in other study in Indian population. So it is really tells us how big the suffer of the patient with vitiligo. Again, psoriasis is not less than vitiligo. almost 50% of the patient will miss their days in the work because of the psoriasis, of the flare of the psoriasis, the psychological impact of the psoriasis. Not only that, but also on those patients up to 87. You know what? It's almost 90% of the patient with psoriasis, their quality of life will be affected. And that has been for sure proven, and we can see it in our patients. 2 times patient with psoriasis, there's a possibility that their chances to be employed is decreases in comparison to a normal person because of the look of psoriasis, because let's say some of the chances or some of the work nature does not necessarily needs a patient who show up as skin diseases. So what's the treatment options? I'll go through very fast on how we attack the pathogenesis, how we normalize the melanocyte stress by antioxidant. But nowadays, there's no proven antioxidant that has been shown to help patients to like recover or to treat the vitiligo. What about inhibiting autoimmune pathway? Yes, there is proven whether with steroids, but however with rebound phenomena. But nowadays, the autoimmune anti-autoimmunity or target autoimmune molecules has been proven, or at least has been shown to be promising way of treatments like the JAK inhibitors. And we hope that in the coming few years, we'll be able to reach a target molecules that can block the pathway of disease activity in patients with vitiligo. Promoting melanocyte regeneration, that this is the main treatment options nowadays through the phototherapy, through the sun exposure, and so on and so forth, or even melanocyte transfer transplant. So yes, we be able to have those patients, but it's not in the ideal or in the, let's say, in the best way. So we give the steroids, calcineurin inhibitors to minimize the autoimmunity, but we cannot give systemic immune suppressive because of the side effects and the rebound phenomenon. So we stick to the topicals. Topicals, unfortunately, is not that so effective. So the second option, which is sometimes be the first options, is the phototherapy. And the good about phototherapy, it attacks 2 ways. It decreases the autoimmunity activities through the Langerhans cells and others depletion mechanism, and also through the enhancing the migration of melanocyte and enhancing the melanin production by melanocyte. So it is probably at this time is the best therapy possible, except sometimes that patient needs to come to the phototherapy, the medication. However, many people in Middle East, they are not aware that the home phototherapy or home phototherapy machines or units are now available, and it can really helps those patients, and becomes very convenient for them to take their sessions at home. They learn how to operate these systems, and it's very easy, honestly. Probably Professor Hamzavi will talk about that soon. What about surgery? As you know, melanocyte transplantation, it is there, but it's not the thing that really we see very satisfactory results in our patients. Antioxidant, until this time, there's no proof an antioxidant helps those patients. So as we said, again, in the psoriasis therapy, there's more options with psoriasis when in comparison with vitiligo. So vitiligo patients really suffer more than psoriasis. Psoriasis patients has better options for topicals, for systemic therapy, including the biological therapy, but also those patients who probably have a reason that they could not use a systemic therapy. Phototherapy is again one of the good options, whether at home office space or home base, for those people who could not come to the office. So phototherapy is really an old and recent treatment armamentarium in our hands, in which it is, yes, old, but that gives us the safety profile of this treatment armamentarium is really well known, and we know how to control for the adverse effects. Just to give you a brief of when the phototherapy started in the beginning of the century, when the phototherapy lamp has been invented, then the Gockerman has started to use the UVB and start to see some result with the broadband UVB. In probably 20 years ago, 20 years later, the methyltestosterone has been isolated, but it takes 25 years before, like 1974, before the doctors start to implement the use of methoxysorolin in phototherapy with BUVA treatments, where P indicating sorolin and UVA treatment followed the ingestion of sorolin, and later on also topical sorolin has been started. 10 years later, the narrowband UVB has been also invented, and that's really make let's say a game changer. Sorolin, it is not without side effects. It has its own side effects, whether photoaging, non-melanoma skin cancer, and so on and so forth, because of the ingestion of sorolin, also raised the enzyme, some gastric upset. So it's not without problems. So when narrowband came up, it really solved many of these adverse effects and also minimized the possibility of non-melanoma skin cancer. So that really make a big change, and over almost like 20 to 25 years, it was probably the main player in the phototherapy units, and the BUVA start to decline, except in very high expert centers where they still use it for resistant cases. Recently, like probably 15 years ago, the home-based phototherapy has become more popular, and people, they start to see the benefits of these home-based phototherapy because of the convenience of having the sessions at home. And this is what also helps the phototherapy to become more beneficial for patients, minimizing also the loss of work, the convenience for patients to have their session at home. So it really make a good change in the treatment therapy with phototherapy, the home-based treatments. So we know that the phototherapy mainly in the range of UVP and UVA, and whether it's narrowband, which is the 311 or 315, which is probably the most effective wavelength for psoriasis and also for vitiligo, where the longer wavelength, which is UVA, also it's effective, but probably it needs higher dosage or need an sensitizer like sorolin. So it became that the narrowband phototherapy is the most selective and the most effective and easy to use with the high safety profile in patients, whether with psoriasis or with vitiligo. So if someone said why sunlight is not enough, it simply said that the amount of UV light reaching our earth is not sufficient to bring the therapeutic effect. So this is why we need the phototherapy units. So if you see a comparison between the BUVA UVA with sorolin, broadband and narrowband, and also excimer laser for the clearance of psoriasis, it's clear from this table that BUVA is most effective, and that's because of the sorolin will be selectively absorbing the light towards the target diseases. This is why it's more effective. However, when the narrowband comes on, it's almost comparable to BUVA, and that's what makes people shift significantly from sorolin to narrowband. Excimer laser, it's also effective. However, it's not good for like wide skin disease. because it's not applicable. And this is just tells you, if someone needs to take capture of these slides, just how many weeks to get the benefits or the clearance of the skin. So there's a comparable outcomes between Buva and narrowband. The guidelines recommendation, again, this is easy to get it. Those people who probably interested, we can just send them these guidelines, and when patient really want to take a lead in treating his patients with phototherapy, nowadays most of the centers, they are going for narrowband, UVB, or excimer, or the home-based phototherapy, which is mainly in the narrowband range. So again, for the adverse effects in the Buva, the major adverse effect is the photoaging. And at my time when I was resident, I was seeing a lot of patients with Buva. And actually, to be honest, there's a significant photoaging. You can see it in those patients. Not only that, but always we need to check patients for non-melanoma skin cancer. So there's always stress on the patients and doctor whether the patient will develop skin cancer or not, especially when he developed this photoaging skin, and the non-melanoma skin cancer might hide underneath some of these Buva lentigens or the photoaged skin. So this is why once narrowband UVB has more the clinical setting, it becomes much better, less side effects, and good outcome without that hassle. So what about excimer laser? We said the excimer laser, because it's costly, it's a laser, it's need an operated expert nurse, and it needs, again, a small limited area, otherwise it's not practical. But still, it's helpful for those patients with the localized disease. So narrowband mode of action, I think it is the same we have discussed before, where the narrowband or the light phototherapy in general, including the narrowband actually, where it induces apoptosis in the keratinocyte. So the diseased keratinocytes will be driven to apoptosis, so the hyperplasia will be decreased. Not only that, but also the promotion of the cytokines will be decreased through the depletion of Langerhans cells pathway. So that means the whole immune driven inflammatory disease will be subsided by the or the, let's say, with the light phototherapy treatment. So it hits more than one line of the pathogenesis, whether it is in the cytokines, blockage, in the apoptosis, or also in vitiligo cases in promoting the repigmentation. So again, this is just explaining these autoimmune depletion of Langerhans cells, T lymphocytes, or the mast cell, and all of these cells are playing a major role in the disease activities. So again, this is just explaining to you the pathogenesis. I don't want to go in the details of that, but you know that T helper 1, which is trigger the inflammatory axis, will be now suppressed in the favor of T helper 2, which upregulate the interleukins 10 and interleukins 2, which works as anti-inflammatory. And that's why those patients get helped by phototherapy treatments. So this is again the histology, where we can see that depletion has been proven by histology that these Langerhans cells has been depleted, and also the other inflammatory T cells, the epidermal T cells will be also less after phototherapy treatments. Again, what happens in vitiligo, we know those people who've been treated with phototherapy, there is very clear, let's say, peripheral pigmentation, which tells us the most likely source for that, and has been proven, is from the hair follicles. There is stem cells in the melanocytes around the hair follicles, and that stem cell for the melanocyte will be activated, will be triggered to be migrated from there to the surrounding skin. And this is why many patients, when being treated with the phototherapy, the pigmentation starts around the hair follicles, which tells us that the source of melanocytes comes from the hair follicle. That's why the pigmentation started as a dots around the hair follicles. So by that, we are finishing just the very brief and comprehensive talk about the pathogenesis of vitiligo and psoriasis. And now we can move to a new, let's say, concept that has been introduced in the world for last, let's say several years, actually almost like 15 years in our country. Probably we are starting that soon because of the needs and also the convenience, especially with COVID-19 epidemic. The home phototherapy becomes a very good and successful way of that. Welcome, Professor Hamzavi will take the leads now for the home phototherapy. And I again thank you for being with us tonight, and enjoy the rest of the lecture. Thank you very much.
Assalamu alaikum, my dear from the Middle East, who have been a friends and homes for me for so many years. And I'm so happy to see my colleague, Dr. Alajlan, present the first section of this lecture. I've known him for almost 20 years, and the hospitality the Middle East has always shown my family, myself, as well as our specialty of dermatology has been tremendous. And I can assure you the growth and success that we've had in vitiligo would not have happened without our colleagues in Saudi Arabia, Egypt, and many of the other countries in the Middle East. So out of respect to you, I'd like to offer this lecture as a small gift. Eid al-Adha is coming up, and here's my little gift to my colleagues in Saudi Arabia and surrounding countries. So Dr. Alajlan, thanks for giving me some time to do this. We're going to talk about home phototherapy and really kind of advance an understanding of how to do that. I've heard that many of you are not doing home phototherapy in your clinics, and I'm hoping that this will kind of advance that therapy. We still do a lot of office-based phototherapy, but home phototherapy is a very nice adjunct, especially for patients with vitiligo or patients with psoriasis that don't have access to this option. So go down to the next slide here. So why should you consider home phototherapy? Well, one of the challenges of home phototherapy is one of the advantages is that its adherence is much better than a clinic. I've been through the traffic of Riyadh, and as many of you know, it is faster to call your family overseas, get a response back, even order your food than it is to go from one section of Riyadh to the other section of Riyadh. So travel is a challenge. People's lives are hectic. With COVID restrictions, it was always very hard to get people in phototherapy. So there's advantages. There's also the resources needed for a phototherapy center. So you have to have your nurses, you have to have your reception staff, you have to have some physician input. So that takes time. So the cost can be lower. So access and cost. And you can also combine it with topical treatments. And lastly, there's a certain level of respect, both in my country, in the United States, as well as in the Middle East, towards people's personal garments and some modesty. And it's much easier to control that in the comfort of your home. Now, there are disadvantages of home phototherapy. You can't deliver the dosing. You don't have the expertise that you can with the outpatient unit, but those abilities of modesty, adherence, cost, those are present with home phototherapy. So who are the candidates for home phototherapy? In general, smaller lesions are good candidates. Patients who have underwent office-based phototherapy and had an improvement are also good candidates. In general, we try to do 4 to 6 weeks of office-based phototherapy before we initiate home phototherapy, unless the patient has significant limitations in coming to the office. In addition, patients who have failed treatments due to adherence, they can't come in 2 to 3 times a week, are things to consider. And then patients with scalp involvement, it's much easier to have the hygiene of their own phototherapy unit, their own handheld unit, as compared to having that in the clinic, which it has to be constantly cleaned. Now, I want to emphasize to you that home phototherapy of the hands in patients with vitiligo is not a good idea, especially the digits. So this image that we're showing you in this particular slide is just to indicate for localized areas. Do not treat the hands with home phototherapy. It will not work in most instances. So what are examples of home phototherapy? The specific sponsor of this particular lecture has a product called the Dermapal, which is a good example of how to take some of the concepts that Dr. Alajlan presented to you and apply them. So it's a simple device. It's got the 2 fluorescent chambers in the handheld device. It's got a comb, which is about 11 centimeters apart. I'm sorry, not 11 centimeters, the appropriate distance apart from the skin. And it's light. It's got a distance gauge, which is something we're going to talk about in a few minutes. It's also affordable. So it's something that I use all the time for my patients with localized psoriasis, as well as localized vitiligo. You can also use it with the comb attachment, which I use in all patients, that will allow you to spread the hair apart. Now, when you're talking about the Dermapal device, realize that that distance gauge is important, because when you take a handheld device and you move further away from the skin, you will be taking advantage of the inverse square law, which basically states that the further the device is from the skin, the less efficacy you're going to have. So you have to make sure that the home phototherapy device touches the skin at a distance that is programmed based upon the output of that device. And that attachment, that comb attachment that you see in this particular picture, helps keep that device at the appropriate distance. So I use that attachment, the comb attachment, on any part. If I'm using the face, treating the shoulders, treating the scalp, I use that attachment because it gives you the appropriate distance. Now, the dosing is based on timer. So in this particular device, you will give the patient instructions on what kind of dose you want. So for example, if you want 200 millijoules and it works out to be about 10 seconds, then you'll tell them you start off at 10 seconds, then you increase it up by 3 seconds, and then you'll get to your cap and you'll stop there. So in this particular example, they're using 30 seconds, and again, they're going up by 3 seconds. Generally, these numbers are about 10% dose increments. If a patient has a significant sensitivity, then you have the ability to reduce the dose. If you have a lesion that's very thick and a psoriatic plaque, or you have a patient who's a tremendous amount of tolerance to light, is a strong or rapid photoadapter, you can go up faster. But in general, 10 seconds, 10% increments are what you want, which works out to be a few seconds, 3 or 4 seconds with this particular device. And across the world, the irradiance of this device is anywhere from 5 to 7 milliwatts per centimeter squared, which usually is a few seconds. 20, 30 seconds at the beginning is about 200 millijoules, and then you increase up by a certain amount of time. But you do not have to worry about programming the joules. All you do is tell them the time. So it should be a simple concept. Start at this time, 30 seconds in this example, increase up by 3 seconds, and then keep going until you hit 1 minute and 30 seconds, and then you stop. So here's the up arrow. This will kind of tell the patient how to program the timer, and use the up arrow to modify the timer to select the units of seconds or minutes. And then you use the other arrows to confirm that. And the video here is showing you that 5 times, and then you press the left arrow once, and then that locks in the time. So you select the unit, seconds or minutes, and then you select the appropriate time, and then you just press the start button like you do with the computer. You put the goggles on in this particular example, and then using that distance gauge that you talked about, you expose the skin to that appropriate light. Now, you can explain how to get the device, and you can work with the Imdad team to get the device to your clinic. Is delivered directly to the patient's house, which is going to respect their privacy. And then Imdad will provide training such as this to ensure that the physician instructions are very clear. The patient records the dose. There's a handout we'll cover in a couple of seconds that talks about the elements you want them to record. There's also handouts available on the National Psoriasis Foundation, as well as the Global Vitiligo Foundation, that allow patients to dose them based on those 2 disease states. This device is FDA approved and is registered in various GCC countries. And here's the example of the documents you need to have. You need to know the treatment numbers, you need to know the dose, and then it's always good to know what that dose correlates to in time. The patients will be recording the time. You'll have to convert it into the dose in joules. But in general, you want to be able to see this so that you know what's the adherence, And then if they have a burn, you want to know at what dose did they have the burn. So you need to have this record. So you just have to teach the patients to fill this record out every time they have a treatment. So how does this work in practical use? In the Pluto study, which looked at psoriasis, they had 14 centers, 23 treatment centers, and they used a home phototherapy unit, a 6-panel device. So not exactly the same device that we just saw here, but a device that is got a panel to it, a smaller version of what you have in the office. And 82% of patients achieve home clearance versus 79% in the outpatient setting. So think about the time and effort it took to achieve 79%. And this was not using a biologic. This is approaching biologic levels of clearance with the newest biologics at a much lower cost and in the privacy of the patient's own home. The total amount of UVB light dose was similar, and the quality of life was better in the home phototherapy unit than it was in the outpatient unit. And then in vitiligo, there's multiple trials. There's the highlight study, and in this particular study, we also have seen a better quality of life improvement, and then the overall result was equivalent to the outpatient unit. However, it takes longer in home phototherapy with vitiligo. A point I want to make again and again that treatments for psoriasis usually take fewer treatments to achieve clearance than to achieve the same level of success in vitiligo, a lot more treatments. And there's not the same percentage that achieves that level of clearance. So you have to select your vitiligo patients very carefully. But again, patients with home phototherapy can also have good success. And so in this particular example in Singapore, they found that there was good repigmentation, greater than 50% repigmentation in about half of patients, but 72%, almost 3/4 achieved good repigmentation with home phototherapy. And that's partly based on the number of treatments needed for vitiligo is much higher than psoriasis. You also have the ability to do it in the privacy of your own home. So it takes more treatments, so you have less of a cost of gasoline, travel time, and missed work. You also have the privacy of your own home. And so the British Association of Dermatologists and the British Photodermatology Group, they provide home phototherapy when there's a geographic need. There's increasing evidence of the cost efficacy, and one of the best options is home treatment. In the United States, we're also doing our own studies called the LIGHT studies to look at the use of biologics versus home phototherapy. So what are some of the treatment pearls that you can use? Dr. Alajlan gave you the theory, gave you the etiology. I'm going to walk through some of the actual treatment pearls of how to do this particular technique. So what you do is that you start off with a dose of light, and you can do it through two methods. You can use the MED method, which is a technique where you measure the minimal amount of erythema that is triggered by your light source, or you can do it without MED testing. Almost everybody in the world does home phototherapy without MED testing. MED testing is really for specialized phototherapy centers, and Dr. Alajlan and myself were trained in that, but again, that's more for specialized centers. So in general, based on the skin type, and the skin type is assessed by questions. So if you tend to burn very easily, your dose is lower. If you tend to burn and then get tan, your dose is a little bit higher. If you tend to almost always tan and never burn, the dose is higher. And then skin type 5 and 6, as we know in the Middle East, is not very well defined in our scale. There are better categories coming up, but basically somebody who's darker skinned, who almost never burns, they're skin type 5 and 6. Most of the time, for most vitiligo patients, I usually start off at 200 because I found that that's a safer zone to increase or start off at. I have fewer burns because you can't rely on just a skin type there. But in darker skin individuals, type 5 and 6, common in the Middle East, for psoriasis, I tend to start at 350 millijoules and increase up. And the reason is that you get more burns in vitiligo than you do in psoriasis, partly because of the type of skin you're treating. The increasing doses are based upon the baseline dose. So for example, in this particular situation, a skin type 5 patient, 350 millijoules is a starting point, you increase up by 60. In vitiligo, if you start off at 220, you would increase up by 25 millijoules, which is about 15 to 20%. Now I want you to go to the upper right corner of the slide, and you can see that the face is at the upper end, 1500 millijoules, and the body is 3000 millijoules. So those are the upper limits of what you want to treat, both for psoriasis and vitiligo. In vitiligo, I tend to stop at 2000, but you can go up to 3000. But the face is a lower dose. What that means is that once you're done, if you have a whole panel that you're treating somebody with, you have to cover the face up and then expose them to the remaining dose. We can talk about that in any questions. What's the endpoint that you want to have? Well, in general, with psoriasis and vitiligo, but especially with vitiligo, you want a light pink erythema, like this carnation here. And so as long as the patient has a light pink redness after the phototherapy treatment within 8 hours and does not exceed going to a dark rose or dark red rose, then they're okay. But if they get very, very red, then you have to start holding the dose. If the erythema is symptomatic, then you have to wait until the skin completely heals, and then you can restart phototherapy. So in general, pink erythema is where you want the patients to be at. And if they're getting too much erythema, you have to cut down your base dose, you have to cut down your dose increment. Now, what happens when they go on a vacation? You come to my home state of Michigan. It's beautiful over here. There's water flowing everywhere. The sun is blue. And that's what it's like 3 months out of the year. The other 9 months of the year, it's cold. But we will go on vacation quite a bit in the summertime in our home state, and people will miss treatments. Well, if they miss a week, you hold the dose. If you miss 2 weeks, you cut it down by 25%. 3 weeks, 50%, and at week 5, you start all over. So it's just the rule of 25%. Hold it for week 1 and then reduce it by 25% for each week until you hit 5 weeks, and then you have to tell them to start all over again. Now, there are exceptions, but you have to use your clinical experience. Pre and post care. It is very important to wear goggles at all times. Do not do home phototherapy on the eyelids, even if your patient has vitiligo or psoriasis or eczema there, unless you really trust that patient. It can become a compromised state if you do that. Review the outcomes of the last session. Whenever you see the patient, see how much erythema they're getting. You want to use petrolatum moisturizer for the treated areas, and this is done after you've treated the area. Before you treat the area, you can use some mineral oil, especially with psoriasis, to increase the penetration. If you don't want an area treated, use sunscreen, but make sure they're consistent with the sunscreen. They can't use sunscreen on Friday and then skip the sunscreen on Saturday or Sunday, have a higher dose, and then get a sunburn or a phototoxic event. In most papers, there's a suggestion that genitalia may have a high risk of skin cancer. It has not been documented, but there's no subsequent studies showing that genitalia does not develop skin cancer. But most of this data comes from the use of PUVA, and the risk with narrowband, the device that we're talking about over here, is very, very low, but we have not been able to document safety yet. In general, for psoriasis, you should have almost clearance at 3 times a week, 18 treatments. So you should bring your patients back around 18 treatments. For vitiligo, it takes many more sessions to assess response, and we'll talk about that in a few minutes, but closer to 24 to 36 treatments is when you want to assess response. So psoriasis, 18, vitiligo, 24 to 36 treatments to assess response. There's also this concept of photoadaptation, and our group helped define photoadaptation in vitiligo. And one of the things we found was that it adapts just as well as normal pigmented skin. And in general, when you have a patient who knows their MED, you can go up to 6 times that amount. Now, for home phototherapy, what that really means is that what's your upper limit? It's 1,500 for the face. It's 3,000 for the body. Don't go above that, and you should be safe. And that's an easy conversion. You don't have to worry about the 6 times the MED in your particular situation. Now, I wanted to talk to you quickly about vitiligo. Vitiligo can have up to a 40% response over 6 months, but in our papers that we did in Vancouver, as well as our subsequent work with other groups and other centers, the feet and the hands do not respond very well. When you look at the overall literature, the face is the part of the body that has the best response. And you can expect around 40 to 50% of people to achieve more than 75% repigmentation. But in the digits, especially the digits, not the dorsum as much, but more the digits, less than 10% of patients will achieve 75% repigmentation, and only about 10% will achieve 25% repigmentation. So just a few dots of color will happen in the digits. So it's important to classify your patient. If somebody comes in with hand vitiligo, especially the digits, not a good treatment. But if they're coming in for facial vitiligo, Dr. Samal Desai from the United States, our new incoming president for the American Academy of Dermatology, he talks about how the face is fabulous. The face is a fabulous place to use phototherapy. And you'll have, and in the majority of instances, more than 80%, you'll have at least 25% repigmentation. And in about 45% of patients, you'll have dramatic repigmentation. Now, there are rapid responders and slow responders, both in phototherapy and in phototherapy for psoriasis and in phototherapy for vitiligo. In general, for vitiligo, within 24 treatments, you know who your rapid responders are. They have numerous freckles, numerous small macules of repigmentation. If at 24 treatments, you're not getting some repigmentation, you can go up to 72 for the patients who really want to know if it's going to work or not. But for the most part, between 24 and 48, you know who your rapid responders are, you know your average responders, and you know your non-responders. And definitely by 72 treatments, you know who your non-responders are. And Dr. Cabrera did some excellent work out of Chile, which is also part of our Global Vitiligo Foundation, Vitiligo Working Group's recommendations. So treatment number 24, if you are looking for a patient who wants a great response, you will know by then. If you're looking for a patient who wants to stabilize or just wants some kind of response, you may have to go up to 72 treatments. But in general, 24 is the magic number for vitiligo patients. And you can find some of these recommendations in this paper. Dr. Al-Jamal from Riyadh was one of our fellows working at the time, did some great work with the rest of our team, Dr. Samia Asmat from Egypt. So lots of contributions of Middle Eastern dermatologists to this global work on phototherapy. And don't worry, phototherapy can be frustrating, but it's something that does get better over time. Here's a summary that you can take a look at, and this will be in your slide deck, that talks about how to administer. And this is more the details of how to dose patients with vitiligo, and that's a summary that you can use. You can also look at some of the recommendations about the post-treatment recommendations, as well as adjunct treatments. Almost always with vitiligo, you have to have an adjunct treatment such as tacrolimus to improve the response. There's also some studies coming out of the Highlight study, which we already covered. And then you all can also use phototherapy for multiple other indications, such as the ones listed over here. Here's some cases and some treatment outcomes of what to expect. Before and after pictures, a patient with pretty extensive psoriasis with significant improvement, just a little bit of PIH, hypopigmentation left over. And again, no biologics used in this. Another example of a young female patient may not be as comfortable coming into the clinic. Another patient, 16 treatments, one of my own patients who could not afford biologic therapy, dramatic improvement with 16 sessions, has remained clear for many years now. Vitiligo on the face, very successful treatment. Look how happy this patient is after the treatment. And again, a dramatic quality of life issue in our Middle Eastern populations. Even early segmental vitiligo, you can also have a response. This is mixed vitiligo, both segmental and generalized, but again, a good response with phototherapy. Another example on the back of the neck. So the take-home message is that the psychological and socioeconomic impacts of vitiligo and psoriasis are detrimental to quality of life. The Middle East has increased its wealth and its quality of life for many of its citizens, and people are expecting a better quality of life. Narrow band with topicals can be the first line for treatment of extensive disease state, and phototherapy addresses both the melanogenic effects as well as the immunologic effects of vitiligo. Dermapal is a very nice localized device you can consider using. It's effective and safe. You can also use the whole booth meters, whole booth devices that we talked about earlier. But again, Dermapal is something inexpensive, is a good introduction to home phototherapy. And with that, we're happy to take questions and answers. Thanks so much for taking the time to listen to the lecture. Thanks for Imdad and Davlin for helping to organize it. And Dr. Alajlan and I are happy to answer any questions. Thank you.
Thanks a lot, Professor Abdulmajeed and Professor Hamzavi, for this sublime and rich lecture. We are looking forward to a lively Q&A session as we have received so many questions till now. And we also thank our 800 registrants who are gracing us with their attendance tonight for their active participation. I also want to remind our attendees that they can still direct their questions to our speakers by following the steps displayed now on the screen. They can also direct their patients to order their treatments through the displayed channels. The first channel is through our website in Daily Market, and through the our dedicated phototherapy WhatsApp number. There's also has been created a coupon code that physicians can give to their patients, and the patients will be receiving 10% discount on their home treatment devices. As for the training and patient education, because we have received many questions regarding this point, our specialists will be applying comprehensive treatment for the patient, starting from how to operate the machine, how to input the treatment parameters or the starting energy that the doctor prescribed, and how to follow up through the several steps, including like putting the gargles and how to protect the surrounding areas. And the most important step of all is how to keep log of all the treatment parameters used in order for the physician to be able to follow during the follow-up session to determine what is the continuation of the next step in the treatment plan. Again, there is a coupon code of 10% discount for your patients they can use during their order, which is UV10. During the following couple of minutes, we will be answering some of the most important questions that we have received during our session. Dr. Abdulmajeed can
Yes, I
can
can.
join us.
Sorry, no problem.
Hi.
Thank you very much for the imdad. Yes, I just want to give my apology for the audience because I got bad viral infection affecting my voice badly. So probably I'll not be able to share with you the questions. I'll just try to answer one of the questions. The first one, which is Dr. Anajla, who said, are we able to modify the dose escalates depends on our needs, or we should follow the protocols. But of course, actually, it is always you can, as a doctor, to modify the dosage according to the patient response and to patient tolerance and the adverse effects. It's always when the doctor who decided which the dosage is better, and with experience, usually doctors is giving better, let's say, better response rate when he modify the dosage according to the patient's needs, not just to the protocol guidelines.